Sabay tayo yumapak sa landas ng medisina. Sabay nating hinarap ang pagsubok at paghirap, hanggang makamtan natin ang matinyas nating pangarap. Pagsikat ng liwanag sa unang araw ng Mayo, sa taon na tinadhana bilang ating sentenaryo, ay biglang natapos din 5 taon ng pagsisikap, 5 taon ng pagsasama sa oras ng saya't hirap. Tayo ang class ng 98, sa simula ng pagkitang tilas sa loob ng PGH, kay busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98, hanggang ngayon may pakitang tilas. Salamat PGH, payaman sa utak at puso. Kailan ba'y di nagkulang sa talino at talento? Ilang dekada bang tayo'y magkakasama? Sabay-sabay tayo yumapak sa landas ng pagkakaisa. Sabay nating harapin tagumpay ng ating ipili, karangalan at galing sa lahat ng ating gawain. Pagsikat ng liwanag sa bawat araw ng taon, pasalamatan natin Diyos na Panginoon, sa alaala at kwento natin ng katuwa at bighatin, sa lahat ng pangyayari na naghubog sa atin. Tayo ang class ng 98, sa simula ng pakitang tilas sa loob ng PGH, kay busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98, hanggang ngayon may pakitang tilas. Salamat PGH, payaman sa utak at puso. Kailan ba'y di nagkulang sa talino at talento? Yung medisina.
Welcome to the UP College of Medicine Class of 1998 webinar series. As this year's Silver Jubilee class is hosting most of the webinars this year on Mondays, Wednesdays, and Fridays, unless announced otherwise. Coming from our successful webinars last year, our 2023 theme is still primary health care in the era of universal health care. In this current webinar series, we hope to unlock knowledge and discuss interesting and relevant topics for primary care physicians, including GPs, family and community medicine physicians, occupational and industrial health physicians, as well as other allied medical professionals. Here are some reminders for a smooth webinar experience. Firstly, kindly turn off your microphone and video for the duration of the webinar. Secondly, we encourage you to participate in an interactive discussion at the end of the speaker's presentation. Feel free to type in your questions in the Q&A chat box in Zoom or through the comment section if you are watching on Facebook. They will be addressed in the open forum after the lecture. Let us now begin with a short ecumenical prayer. Almighty Father, we praise and thank you for this day. We come to you asking for blessings and help for our speaker, moderator, and everyone present right now. We pray for your guidance as we unlock knowledge together. We ask that you show us how to conduct our work clearly and with a spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and further to be the best we can be for others. Amen.
Good afternoon to everyone on Zoom and those watching on Facebook and the UP Manila live streams. Before we proceed, let me introduce myself as your moderator today. I'm Dr. Hazel Zulig from the UP College of Medicine, class 1998. I'm also the president of the Brain Foundation of the Philippines and currently an adjunct professor at the UP College of Public Health. I'm a neurologist. More importantly, allow me to introduce our guest speaker today, proudly my classmate, Dr. Deborah Ignacia David Ona. Dr. Ona should be familiar with all of you, especially the loyal attendees of these webinars, because she's a frequent speaker. She is an associate professor at the Division of Hypertension, Department of Medicine, UPPGH. She is the immediate past president of the Philippine Society of Hypertension and a consultant at St. Luke's Medical Center. The topic today is very interesting. It is applicable whether you're practicing in an isolated area, in a rural area, or you are in a very advanced medical center, because hypertensive crisis is one of the scariest things that we can possibly face in the emergency room. So Dr. Ona would be the best person to give us enlightenment on this particular topic. So thank you for taking time out to join us today, Dr. Ona.
Thank you, Hazel, for that generous introduction. So, big shout out to Hazel because it's around 3 a.m. in the morning in her time zone, and I'd also like thank you, Hazel, for doing this for us, and I also like to thank everyone, despite being the holiday, you're here to learn. So, as Hazel mentioned, we will talk about hypertensive crisis, the management of hypertensive crisis. Hazel, being a neurologist, will help me out with the questions when there are questions regarding neurology later on. So these are my disclosures. So the objectives of the talk is to differentiate hypertensive urgency versus emergency, which is usually the common question that we get. Discuss the algorithm in the management of hypertensive crisis. And I think this is important for the ones who are in the front lines. Discuss indications for subspecialty referral in patients with hypertensive emergency. So what is hypertensive crisis? Hypertensive crisis is divided into two, an emergency and urgency. So basically, if the blood pressure is 180, more than 180 over 120, it's considered a hypertensive crisis. What differentiates a hypertensive emergency between an urgency? If there's impending or progressive target organ damage, then that patient is in hypertensive emergency. But if it's just elevations of blood pressure without target organ damage, it's known as hypertensive urgency or severe uncomplicated hypertension. So,
Debbie, excuse me. We need to see your slides.
Ay, hindi pa ba? Ay, wait Sorry. Hindi ba?
Hindi pa nasi-share.
I need to share it. Sorry
Okay lang.
Masyadong
We need to get the definitions.
Yeah. Masyadong na-excite. So here, kala ko na-share ko na. So basically, severe elevations of blood pressure, so 180 over 120, complicated by impending or progressive target organ damage. So hypertensive urgency is elevations of blood pressure without target organ damage. So ang ano natin is if the blood pressure is 180 over 120, the next question that you'll ask yourself is if that patient has impending or progressive target organ damage. So when you're faced with a patient with a 180 over 110 diastolic blood pressure, so it can be detectable by clinical or laboratory criteria. So when the patient comes to you, the only thing that you need to ask yourself is if there's evolving target organ damage. So for these types of patients, immediate treatment is required. But if that patient is in hypertensive urgency based on the history and physical exam that you've done, then you have to have less rapid reduction in blood pressure. In the perioperative environment, patients are already hospitalized. So the management of hypertensive crisis should likely be the same for both urgency and emergency. So just to give you a background of hypertensive urgencies and emergencies, it is thought that only 1% of patients with hypertension would eventually present to the ER in hypertensive crisis. This is because the assumption that because of the improved treatment of chronic hypertension, it should lead to a reduction in the incidence of hypertensive emergencies. It is estimated that between 1 and 5% of persons with hypertension will develop the hypertensive crisis at some point in their lifetime. And then hypertension that was unknown at presentation was present in 8% of hypertensive emergencies and 28% of hypertensive urgencies. So when a patient comes to your clinic or in the emergency room, rarely they present with hypertensive emergencies. Usually urgencies lang po yan. In a single-center Italian study, hypertensive urgency or emergency accounted for 3% of all medicine admissions and 27.5% of all medical emergencies. So, konti lang dapat siya. So, ang ratio is mas madami urgency kesa sa urgency. So, it's a 3-to-1 ratio. Patients with hypertensive urgency much more likely are unaware that they are hypertensive than those with emergency. This is a ongoing study in Italy. They actually looked at the people coming into the emergency department and trying to see which of those people are in emergency and urgency. And then they followed them up and then saw if they have already subclinical hypertension-mediated organ damage. So, kung dati po yung term natin, target organ damage, ngayon, ang term po natin is hypertensive-mediated organ damage. So, this is a preliminary report. So, they had a cohort of 122 patients and the admission blood pressure is around 201 to 113. And out of those 122 patients, only 18 patients are in emergency and 114 are in urgency. So it actually tells you that most people that come to the emergency room do not really present with hypertensive emergency. When they followed up these patients who are in urgency, so less than 72 hours, 34.4% of those 114 were normal, and the rest are are considered hypertensive. So they actually are following up these patients basically, and then we'll be able to know the results after a year. So this is just a new study that's been ongoing. What are the important differentials? So we need to define resistant hypertension and accelerated hypertension. So resistant hypertension in the previous lectures that we've done is defined as a blood pressure that remains above goal despite concurrent use of 3 antihypertensive agents of different classes, one of which should be a diuretic. Or if you follow the European definition, it's patients whose blood pressure is controlled with 4 or more medications, one of which is a diuretic, are considered to have resistant hypertension. So we need to distinguish resistant hypertension with end organ damage, those with renovascular hypertension versus those with accelerated hypertension or hypertensive crisis. So accelerated hypertension is defined when a blood pressure which was mild or moderate suddenly rises ang pinaka-importanting tingnan dito sa mga pasyenteng to is their eye grounds. So you have to do a fundoscopy and then see if there are some fundal changes, but no papilledema. When there is papilledema, the hypertension is called malignant hypertension. So importante na meron po kayong fundoscopy and try to see if that patient has papilledema or some fundal changes. When the blood pressure reaches a critical level, a map of 150 in experimental animals in patients with accelerated hypertension, fibrinoid necrosis occurs in the anterior walls. So what are the triggers of hypertensive crisis? Usually, the number one is non-compliance with medications. Sometimes, kinakalimutan nila yung medications nila or hindi nila, bigla nilang sinastop. Or sometimes drug use. So sympathomimetic use like ephedrine, pseudoephedrine, illicit drug use if you have to elicit cocaine, your illegal drugs, PCP, at amphetamines. Rebound hypertension after abrupt discontinuation of a short-acting sympathetic blockers like your clonidine, your beta blockers. Alcohol withdrawal or intoxication can also lead to a hypertensive crisis. Herbal remedies, thiamine ingestion using your monoamine oxidase inhibitors, and secondary causes of hypertension. So by just doing the history and physical exam, you'll be able to know what the triggers are and what the causes are for the increase in the blood pressure. So we go to hypertensive emergency. So we said that it's defined as an acute elevation of blood pressure associated with end organ damage, specifically brain, stroke, heart attack, aorta if there's aortic dissection, kidneys if there's acute renal failure, in the eyes if there's papilledema. So for emergencies, it represents between 0.5 to 0.6% of ER visits. So it estimated that 1% of patients with a history of hypertension will develop a hypertensive emergency. What is the pathophysiology? The thing about hypertensive emergency or crisis, it's poorly understood. They said that there's a sudden increase in systemic vascular resistance. So we know that blood pressure equals cardiac output times systemic vascular resistance. So when there's an increase in systemic vascular resistance, then there's an increase in BP. So they said it's secondary to circulating humeral vasoconstrictors. The critical arterial pressure is reached, which overwhelms the organ to compensate for the increased pressure, thereby limiting blood flow. And they said that the renin, angiotensin, aldosterone system is also activated. So basically, all of the things that can lead to an increase in the blood pressure actually is part of the pathophysiology of hypertensive emergency. So what are the symptoms? So we said that stroke symptoms, agitation, delirium, head injury. You have visual disturbances, papilledema, flame hemorrhages, chest pain if you have myocardial ischemia or acute coronary syndrome, back pain or chest pain if you have aortic dissection, dyspnea if you have pulmonary edema, acute kidney injury, and if you're pregnant, eclampsia, or if that patient has taken hyperadrenergic drugs, then they can have hypertensive emergency as well. So if you distribute the acute, this is in 2004. If you look at the distribution of acute target organ damage and hypertensive emergencies, more than half are cardio-related, 40.5% are brain-related. So for cardio-related, the most common would be your acute pulmonary edema, followed by your myocardial infarction. For brain-related, it's still ischemic stroke, followed by hemorrhagic stroke, followed by subarachnoid hemorrhage. So this is the pathophysiology for hypertensive emergencies. For encephalopathy, it's a hypertension leading to endothelial dysfunction and cerebral edema. For intracerebral hemorrhage, may pumutok na either aneurysms or microbleeds. For cerebral infarction, may nagbara. So it's either through thrombosis, embolism, or decreased perfusion to the brain, so hypoperfusion. Aortic dissection, when there's intimal tear with dissection into the media of your aorta, it's either secondary to uncontrolled hypertension or it's a congenital anomaly. For myocardial infarction or ACS, it's because there's thrombus or plaques in your coronary arteries leading to pagbara ng mga coronary arteries nyo, leading to ischemia or infarction. Acute LV failure would be the activation of your neurohormonal cascade, salt and water retention, increased vascular resistance, bagsak yung cardiac output mo, and increased pulmonary pressures. Renal would be secondary to either benign nephrosclerosis or vascular glomerular or tubulointerstitial changes. Preeclampsia, it's primarily a disorder first pregnancies, unknown etiology. Basically, they say it's likely related to incomplete trophoblastic invasion and alterations in your immune responses. And your catecholamine-induced states can be either direct or indirect effects. When you're taking a lot of drugs, illegal drugs, can actually increase your catecholamine surges. So how do we manage hypertensive crisis? In the emergency room, when the patient comes to you, a thorough history, tama yung mga professors natin in medical school, a thorough history and physical exam to identify the cause of the hypertension is important because we need to differentiate between two entities, whether it's emergency or urgency. You have to elicit acute and chronic end organ damage and do pertinent labs and ancillary tests to help in the diagnosis. So this is a position statement by the British and Irish Hypertension Society, which was done in 2023. If you have a patient with suspected hypertensive crisis, the next step that you need to ask yourself is there acute life-threatening end organ, or is there retinopathy grade 3 or 4? If the answer to that question is no, then that patient might just, if the blood pressure more than or equal to 180 to 120, then that patient is in acute severe hypertension. Hindi na nila ginagamit yung term na hypertensive urgency. Ang term na po nila is acute severe hypertension. So it's a severe elevation in blood pressure, usually more than 180 to 120 without evidence of acute and or life-threatening end organ damage. If the blood pressure is less than that, then that patient might be just hypertensive. So just follow the guidelines that we've lectured on you. We have Philippine guidelines for that, for the management of hypertension. But if that patient has eye changes, so if it's just eye changes only, then that patient might have malignant or accelerated hypertension. If it's eye changes plus another thing, then probably that patient has hypertensive emergency. And I've already discussed to you acute life-threatening and organ damage examples. So basically, in this setting, the thing that you need to confirm is if that patient is really hypertensive. And so you need to measure in both arms using correct sized upper arm cuff, and then do a thorough physical exam and fundoscopy and do some of the tests. So if that patient we go to acute severe hypertension or hypertensive urgency. If that patient is a known hypertensive, then what you do is you just up-titrate the current medications or add new therapy. You need to check adherence because the most common cause is they just abruptly stop their medications. And then third, you have to screen for secondary hypertension. If that patient is not a known hypertensive, then what we do is if the 24-hour ambulatory BP is available or is affordable, then you can do that. Or you just ask your patient to do home blood pressure monitoring to rule out white coat hypertension. And then you consider starting therapy in selected patients, consider secondary causes of hypertension, and arrange follow-up within 7 days. And then if that patient is a confirmed hypertensive, then you start therapy as we have discussed in the Philippine guidelines. And then you want to aim to reach target PP within 6 to 12 weeks by frequent up-titration therapy and frequent follow-up. So we know that the management goals of hypertensive urgency, which is always the question that we are asked, it's known as severe uncomplicated hypertension or severe hypertension. We need to just lower the blood pressure gradually over 24 to 48 hours with oral medications, not sublingual. We optimize or restart their current treatment regimens. Do not aggressively treat the patients with IV drugs or oral loading. Ensure that the patient has a follow-up appointment within a few days. So in patients with asymptomatic, markedly elevated blood pressures, Thus, emergency room medical intervention reduced rate of adverse outcomes. So in a study that they saw, routine emergency room medical intervention is not required and should be referred for outpatient follow-up. In select patient populations wherein they're geographically isolated areas, yung GIDA na tinatawag, or poor follow-up, physicians may treat markedly elevated blood pressure in the emergency room and or initiate therapy for long-term control. Alam ko marami sa inyo na may mga pasyente sa geographically isolated areas. So these are the exceptions to the rule. So if you look at the data, do we need to treat hypertensive urgency right away? We see that treating patients with hypertensive urgency without target organ damage may increase 30-day and 1-year mortality and may increase complication rates. There's no evidence of benefit with treatment to acutely lower your blood pressure. So what we need is to observe that patient in the emergency department. We do wait, then treat approach. Because in a study, it shows that 32% will reduce their blood pressure, will have their blood pressure reduced, or 30% within 30 minutes of quiet rest. So dalin mo lang sila sa isang quiet room, then their blood pressure will spontaneously decrease. The rest were managed on antihypertensive medications and sent home. So if you have 100 patients with hypertensive urgency, 30% non kakalma yung BP nila if you put them in a quiet room, and 70% you just need to manage them on hypertensive medications. There's no serious hypertension related or post-intervention adverse events during telephone follow-up after 48 to 72 hours. So we need to gradually lower the blood pressure during a period of hours to days. We minimize risks associated with rapid blood pressure reduction, myocardial infarction and stroke, or impairment of autoregulatory mechanisms that maintain tissue perfusion. We prevent deleterious cardiovascular sequelae that may result from insufficient or too slow blood pressure reduction. So in selected social or clinical situations, physicians may choose to initiate treatment for markedly elevated blood pressure in the asymptomatic patient before discharge to gradually lower the blood pressure or initiate long-term control. Ito yung you have to individualize treatment. So if you know that that patient is of poor follow-up, has limited access to care, is of older patients, then you can initiate treatment while in the emergency room or while in the clinic. So this is an algorithm that we saw. This was in Journal of Clinical Medicine 2022. So for symptoms of elevated blood pressure, if the blood pressure is more than 180 over 110 or 120, if there's no target organ damage, then that patient has uncontrolled hypertension. Then you just treat, discharge, and follow up. If there's acute hypertension-mediated organ damage or MOD, AH-MOD, so acute hypertension-mediated organ damage, these are the mandatory laboratory tests that you want to do to be able to rule out secondary causes or rule out target organ damage. And we said that there are 4 buckets. Either it's cardiac, it's renal, it's stroke, or preeclampsia, eclampsia. So if it's cardiac, these are the tests that you want to do to rule out acute coronary syndromes, CT angio or CT scan if you're ruling out aortic dissection. For renal, acute renal failure, then you do urinalysis for protein, ultrasound, and creatinine. For acute ischemic stroke, it's a CT scanner and MRI. For eclampsia, preeclampsia, then you have to rule out other causes. And if the patient has confirmed hypertensive emergency, then what do you need to do? So for symptoms, usually it's headache, visual disturbances, chest pain, dyspnea, focal or general neurologic symptoms, dizziness, GI complaints like abdominal pain, nausea, and anorexia. So for acute life-threatening and organ damage or retinopathy, yun, pupunta tayo doon. If that patient is just eye changes, baka malignant or accelerated hypertension, then you just treat with oral therapy with a calcium channel blocker or a beta blocker unless contraindicated. Ensure frequent monitoring such as on ambulatory care. Some patients will benefit from inpatient admission and monitoring. If that patient is in emergency, then that patient has to be admitted to either level 2 or level 3 care, whether it's a high dependency unit or an intensive care unit. And we need to give intravenous therapy and BP monitoring based on the diagnosis. And then pace and target for blood pressure reduction is based on the type of target organ damage that that patient has. And then after all of this, then you have to aim to reach target BP within 6 to 12 weeks by frequent up titration in therapy and frequent follow-up. So the general principles of hypertensive emergency: you reduce mean arterial pressure by less than 25% in the first hour, with further gradual normalization of BP in 24 to 48 hours. Huwag tayo masyado aggressive sa pagbagsak ng blood pressure sa mga patients with emergency. For ESC, reduce blood pressure by the less than 25% in first hours and subsequent cautious reduction thereafter. So treatment targets depend on the type of target organ damage. So current treatment is founded on agents that can be administered. So the cornerstone of treatment for these types of patients should be IV, titratable medications that are short-acting, because in order to avoid excessive hypotension and further ischemic target organ damage. So pag hypertensive emergency, automatic po yun, IV, titratable, short-acting medications. So if you look at this diagram, you see that majority of the treatment, depending on your target blood pressure, so if it's stroke, depending on if it being ischemic or hemorrhagic, so basically the principle behind it is that you don't really bring down the blood pressure as soon as possible. And if you look at the treatment, majority of the treatment that you see, nicardipine, is IV, titratable medications. So the target BP should be obtained gradually in a controlled manner and without compromising organ perfusion. So these are the medications for hypertensive emergency, depending on the type of emergency that you have. So majority, you see that nicardipine and labetalol. So unfortunately, we only certain medical centers have labetalol, but if we don't have labetalol, then nicardipine is an option. And these are the medications to avoid for different types of hypertensive emergency. But if you want to err on the side of caution, then nicardipine is a drug that should be available in your centers if you're a level 2 or level 3 center. And these are the this is the mechanism of action for the parenteral drugs used in hypertensive urgencies and adverse effects. The thing about your parenteral medications is that they're really short acting. So you can titrate up or down if your blood pressure really goes down really very fast, then you can titrate your medications to be able to maintain a steady state of blood pressure that you want to target. Okay, so what about subspecialty referrals? So the presence of end organ damage are logical reasons to refer. So we say that if your patient has had a stroke or hypertensive encephalopathy, whether it's infarct or hemorrhage, then you have to have a stroke team there or a neurologist there. If your patient has ACS, acute coronary syndrome, then you have to have a STEMI team there, because there's a door-to-needle time wherein you can really save your patient, basically. So there's a time is of the essence for patients who've had a stroke and who've had ACS. Nephrologist if your patient has renal failure, ophthalmologist retinopathy, and OB for preeclampsia and eclampsia. So this is basically what I've lectured in a nutshell. So if you have severe hypertension, if the blood pressure is 180/110, you look at the fundoscopy, eye grounds. If you see that there's hypertensive neuroretinopathy present, then you treat malignant hypertension. If hypertensive retinopathy is absent, or but there's acute end organ dysfunction, then you treat as hypertensive crisis. If there are no end organ dysfunction or no papilledema, then you treat your patient as severe uncomplicated hypertension. There are 3 steps. Number 1, you have to educate your patient regarding the chronic nature of hypertension and tell them the importance of long-term compliance. So in hypertension, the medications are forever. Parang love life, it has to be forever. And the blood pressure should be controlled to prevent complications. Step 2, you have to evaluate the reason for inadequate blood pressure control and adjust the maintenance antihypertensive drug regimen. So if the patient is non-compliant, there are 3 things that make your patient non-compliant. The patients ran out of medication, so you have to restart. Are there drug side effects? Then you switch to a drug without side effects. If the patient cannot afford drugs, you say that there's a program of government wherein the drugs are free. So you have to switch them to medications that are free or drugs that they can afford. If your patient is compliant with the current blood pressure regimen, then probably your patient cannot be controlled with monotherapy alone. So you have to start with combination therapy at the outset. And in step 3, you have to arrange outpatient follow-up to document adequate BP control over the ensuing days to weeks and change the drug treatment regimen as required. We said that 6 to 12 weeks is enough to be able to titrate up and down your medications to be able to have that patient's hypertension under control. So I guess the take-home points that we have is that we need to adequately follow up our patients. I've discussed extensively the difference between an emergency and urgency or severe uncomplicated hypertension. We say that there should be no sublingual meds for hypertensive urgency because I've discussed with you why their blood pressure becomes uncontrolled. And for hypertensive emergency, we need to treat them with an IV antihypertensive medications, and they have to be transported to a level 2 or level 3 hospital where they can be treated very well. So I think that's the end of my talk. Thank you so much for listening. Hazel, back to you.
Thank you very much, Debbie. And thank you for such an enlightening talk. Now we're about to begin our open forum, but first we'd like to thank our sponsor, MedInfinity, for helping us make this Class 98 webinar possible. Okay. Debbie, are you ready?
Yes. Meron bang questions sa stroke? Ikaw na yun.
Meron na. Meron ng mga questions. And there are, actually, maraming clap. Now, there is one question here. How would you manage an 85-year-old patient whose BP is normally under 140 over 90, but once in a while, maybe once a month, rises above 180 over 120?
That's a good question, Hazel. So basically, our definition, the Philippine guidelines that we've made, the definition for hypertension in the elderly to be able to give treatment is a blood pressure more than or equal to 150 over 90. Because we know as they grow older, their arteries become stiffer and their blood pressure becomes higher than normal. So we only treat if the blood pressure is consistently more than or equal to 150 over 90. If it occasionally rises to 180, 120, then you need to look at other causes. So for elderly, you have to look at stress, anxiety, and pain, because we know that our blood pressure varies throughout the day depending on the stimulus that we have. So if we become excited, then our blood pressure goes up. If we are in pain, then our blood pressure goes up. The operative word, it has to be consistently high, because if it's not consistently high, then that patient is really not hypertensive. Then if you give that 85-year-old an antihypertensive medications, then probably that blood pressure will go down, and there are a lot of side effects for elderly patients. So ayaw natin sa mga matatanda pag medyo naging dizzy sila, pwede silang mahulog, magpa-fractures. Ang daming complications. So, my advice to that doctor is to have the elderly patient do home blood pressure monitoring and then try to see if the blood pressure is consistently high. And the cutoff for pharmacologic treatment for 85 years old and above in the Philippine guidelines is a blood pressure of more than or equal to 150/90. If it's not consistent, then that patient is not hypertensive. You have to look at other causes why the blood pressure is high.
Thank you. That's a good point, Debbie. No, we see that all the time. Patients, for example, they have headache and then their blood pressure goes up, and then they want you to treat the blood pressure, and you want to tell them you treat the headache because it's the headache that is causing the hypertension, not the other way around. So that's a good point. Sometimes pain is being missed as a cause of hypertension. How much of a factor is anxiety, Debbie? Do we only see that in the movies?
Dami,
For
especially for
hypertensive crisis. I mean, yung biglang anxious.
nakita nila dun sa isang study, it's 32% of emergency room visits. It's because of anxiety. But we don't really have data here in the Philippines. We just have data. Mga 30% of those going to the emergency room, probably it's anxiety, because when you bring them to a quiet room, then their blood pressure goes down. That's why in all of the trials, in the SPRINT trial, that's a landmark trial, they actually check the blood pressure while that patient is alone in a quiet room. So basically, they know that there's this white coat effect when they see doctors, when they see nurses, their blood pressure really goes up.
Do you
But
ever
we
give
don't-
anti-anxiety medications
Yeah.
for patients? Yeah.
Yeah.
That's a good. Yeah, because sometimes we doctors tend to say, I mean, after all the tests and everything, you say, siguro you're just stressed, no? And then we forget to treat the stress or the anxiety.
A
or
lot
the blood
of I'm sure you, Hazel, have a lot of patients because your patients have gone through a lot, like post-stroke, most of them would need, like for elderly, I've seen a lot now, that giving them anti-anxiety medications helps a lot because they have a lot. Hindi ko alam kasi siguro wala sila masyadong ginagawa, so ang dami lang na iniisip, di ba? So basically, some of them, or not majority of them, are on anti-anxiety pills already.
Not the benzodiazepines though,
Not,
because
no.
because of the addiction, but sometimes
Yeah.
you may want to give a low dose antidepressant
Yeah.
just to control the anxiety if you really can't have difficulty controlling the blood pressure. I mean, anxiety related hypertension. Debbie, one more question. You said to observe the patients, you emphasize very much the very slow correction of the high blood pressure. And I'm very happy for that as a neurologist because I'm always worried about the perfusion in the brain if you suddenly have a drop. But when you are in the outpatient or you are in an emergency room, they say you put the patient in a quiet room and you're monitoring. Say you started with 180/120 and then you gradually reduce. When is it safe to discharge the patient?
Basically, what they say is if it's urgency, it's 25% reduction in blood pressure. 160 is enough, is okay, as long as that patient, you know that patient will follow up. Because some patients, they don't really follow up. So you have to educate them that they need to do either 24-hour ambulatory BP monitoring or do home blood pressure monitoring. You're correct, Hazel, because we know that for hypertensive patients, their cerebral perfusion pressure is at a high set point. So if we bring down their blood pressure further, then that patient might suffer either a stroke or a heart attack because yun nga, yung set point nila based sa normal patients with normal blood pressure is not the same. So basically, what actually propels the blood flow to the heart is your MAP, diba? Your mean arterial pressure. So if you bring down your blood pressure really low, then you'll see that these patients might become dizzy, etc. So you have to have a gradual reduction in blood pressure. Kaya nga importante, the education part. You have to tell them that, okay, I will let you go, but you have to monitor your blood pressure every day, and then try to follow up with the doctor in 3 to 5 days. If the blood pressure is still high and you feel something, then you have to go back to the emergency room. Masaya ka na ba, Hazel? Kasi yun yung yung
Sometimes kasi ang hirap ipaliwanag dun sa patients. In a patient who has a stroke, for example, halimbawa po barado yung ugat dun sa brain, konti yung pumapasok na blood flow sa brain. Ang ginagawa ng katawan, medyo tini-turn off niya yung circulation sa other parts of the body para ma-prioritize yung brain. And in that process, the blood pressure goes up. So, sabi ko, huwag kayong magre-react doon kasi ginagawa yun ng katawan para magkaroon ng circulation to the brain. Pag binagsak mo yung blood pressure, lalong lalala yung stroke. So sometimes, paresis lang, mahina lang yung one side, biglang nagiging full paralysis kasi nagbigay ng sublingual. No? So kaaway talaga natin yung sublingual. So it's good that you emphasize that the good thing about nicardipine IV is you can go up and go down with your BP IV control. Yung sinaksak mo sa ilalim ng dila, mahirap mo nang hilahin kung biglang bumabagsak yung blood pressure. No? But
Kasi
that's one question. There was one in
Yeah.
a far-flung area, you were mentioning Gida. If nicardipine is not available, can we still give oral antihypertensives like clonidine and nifedipine given orally, not sublingually?
Orally, problema kasi sa clonidine, the effect of clonidine is 6 hours. So if you give clonidine and the blood pressure really goes down really, really fast, then you actually are doing a disservice to that patient. Because if that patient is ischemic, may ischemic penumbra ka, di ba? So babagsak, lalong lalaki yung stroke mo. So that's what we're trying to say to DOH. You have to have nicardipine, especially in the areas, in the geographically. I don't know how it's going to happen because we're doing a partnership with Iloilo right now and WHO. So they have geographically isolated areas. Teleconsult can be part of it as long as in those areas there should be, wala rin daw silang cellphone eh. So I told them, I don't know how it's going to happen. Maybe you can write Elon Musk to give you like that, diba? There. So that if there's a patient that have, malayo kasi daw eh, tapos walang cellphone signal, etc. Iniisip ko sana teleconsult, diba? At least meron silang gamot doon, instructan mo lang paano gawin, etc. So, we're not in that position yet, but we're trying to ask government to do it, especially for those in the GIDA, yung geographically isolated areas in the Philippines na meron pa na walang cell signal. But we're trying to work out. Nicardipine is in the PNDF. So it should be available.
I think one of the hesitation is you're committing a patient to an IV. Kasi parang minsan baka naman mapababa ko, and that is why. And then there's another question here, no? In some company clinics, they only give catapres for a hypertensive crisis.
Nako, wag na.
Yun na nga eh.
Yun.
But in a company clinic, I don't think they're equipped with an IV. They can do IV, they can insert IV, they have So
that's why I discuss further the emergency and urgency. For emergency, definitely you need to bring that patient to an emergency room. For urgency, tatlo lang po. Halimbawa, yung pasyenteng yon, meron siyang dose for medication sa gabi. You just give that medication to that patient orally. You don't need to do clonidine. So halimbawa, may amlodipine siya sa hapon. So you just give them the amlodipine that they have. Kung nakalimutan nila yung gamot nila, painumin mo lang yung gamot nila. Kung kulang yung gamot nila, yun yung ginawa rin namin nung sa vaccination Kasi nung vaccination, maraming pasyente na hindi nila na hypertensive sila. So ang sinabi namin, you just give oral amlodipine, 5 milligrams, then after 15 to 30 minutes, check the blood pressure and the blood pressure will go down. But if that patient is in emergency, you need to have that patient in the emergency room because you need to give them IV titratable medications. Ang maganda kasi sa nicardipine, 5 to 10 minutes lang siya. So kahit IV push mo siya, mawawala yung effect niya after 10 minutes. So hindi matagal yung bagsak ng BP as opposed to clonidine and captopril. Clonidine 6 hours to 8 hours yan eh. Pag binaba mo yung blood pressure niya, yun yung palaging sinasabi ko sa mga pasyente, mahirap pong pataasin, madaling pababain ng BP pero mahirap pataasin. And we've seen a lot of patients are given clonidine, sometimes talaga pong nagpo-progress eh, yung stroke nila, nag-MI.
You will see it before your
Maraming
eyes
ganon.
na
Yeah, as
nag-worsen
in,
yung stroke nila.
na wala kang magagawa kasi nandun na yung clonidine sa system niya.
Nakasalanan nung first line doctor kasi nagbigay ng sublingual. Yun is, sometimes it's a knee-jerk reaction. Sometimes it's because there's a lot of pressure in the family. Pinapagalitan ka talaga nila if you're the frontliners. And nakikita nyo na nga na yung blood pressure 170, 180, wala kayong ginagawa. It's very hard to explain to them, wala akong ginagawa kasi I don't want to make the thing worse, diba? So that is good. Some questions here. How do you treat a patient with isolated high diastolic blood pressure?
Diastolic? For diastolic, pag diastolic blood pressure, majority niyan mga bata eh. So, usually 130 over 100, 130 over 90. So, again, you have to look at the modifiable and non-modifiable risk factors. So, ito palagi sinasabi ko. Ang non-modifiable, 3 lang po. Family history, age, and sex. So, sinasabi ko sa kanila, kung may chance po kayo mag-asawa, you choose wisely because you cannot, hindi mo mapipili yung parents mo, hindi mo mapipili yung anak mo, pero mapipili mo yung asawa mo. So choose wisely with a good family history. So basically, the non-modifiable you cannot do without. But the modifiable risk factors, because we see a lot of teenagers now are obese because basically our diet is westernized na, hindi na katulad ng dati. So you look at the modifiable risk factors and try to modify it because if you treat that patient with diastolic blood pressure, especially if they're young, then they have to be on medications for life. If they can modify whatever they need to modify, weight, diet, exercise, if they're smoking, if they're drinking alcohol, then if they can try to veer away from that, modify their lifestyle, then probably they can stop the medications. But if they cannot do that, then kailangan mo magbigay ng gamot. Kasi ang definition natin ng blood pressure is more than or equal to 140 over 90, whichever is higher, whether it's the diastolic or the systolic. But for mga bata na highly motivated, kasi kawawa naman sila kung magbibigay ka ng gamot. And once you start them with medications, I'm sorry to tell you, it's like love life, it's forever. Parang love life, may forever. So your medications, once you start them with medications, it has to be forever. Because
even if it's controlled.
Yeah, because
sometimes that's, some doctors fail to explain that.
Yeah.
So we start them on a good antihypertensive and we get a good control. Below 120 na, doc, pwede ko nang itigil.
Unless you want to unless you want to see Hazel, a neurologist. So you want to do it because you want them not to have complications of hypertension.
Okay. Another question, can we manage the hypertensive urgency with furosemide?
Basically, depending on what type of urgency is that. So if that patient is overloaded, if that patient has acute LV, pero ano na yun eh, pag ganyan, acute LV dysfunction, that's hypertensive emergency na. Pag renal crisis, that's hypertensive emergency. For urgency, usually 3 lang po, di ba? Either nakalimutan yung gamot, kulang yung gamot, or newly hypertensive. You can start with any of the first line medication. So 5 po yun. ACE, ARB, calcium channel blockers, thiazide or thiazide-like diuretic. You can give any of those medications for these types of patients. Furosemide is bandang huli na po yun eh. Pang fifth or sixth line of treatment. Pero meron pa po kayong 5 na pwedeng yung gamitin. Whichever you're comfortable with. We know that amlodipine is a good antihypertensive medication and it's cheap, so it can bring down your blood pressure in 20 to 30 minutes, and then try to monitor your BP afterwards.
So in the case of if you do not have any access to IV medication, you're saying that amlodipine 5 milligrams may do the trick.
For
but
urgency.
For urgency. Okay. So if a 46-year-old patient with blood pressure of 180/120 is experiencing nape pain and flushing but remains conscious, is it urgency or emergency?
You have to look at the target organ damage. So pag stroke, be fast, di ba, Hazel?
Kailangan
So,
na look for the lateralizing signs. Neuro exam po kasi yan. Hindi, that's another thing. Hindi po totoo ang chismis na pag mataas ang blood pressure, sumasakit ang batok.
Yeah.
It's always something. Masakit kasi yung batok ko kaya nagpa-BP ako, and then the blood pressure is high. Kaya mataas yung blood pressure kasi masakit yung batok. So kailangan gamutin yung masakit na batok. But if it's really documented, it's more than 180/120 as the doctor was asking, then tama, ano? You said if there are no lateralizing signs, you're not thinking that it is a stroke or that there is an end organ damage, or it's a complicated, as you said, a complicated severe hypertension, then you can just start your antihypertensive medications and send the patient home. So hindi kailangang hintaying mag-below 120 before you can send the patient home.
Yeah.
As you said, you can give the patient 6 weeks for you to stabilize the blood pressure. Hindi kailangang madaliin, no? So you can give your antihypertensives time to work and really naturally control the blood pressure.
So kailangan talaga mag-physical exam po tayo.
Patient already
Matinding history. And physical exam. Neuro exam po, hindi po natin pwedeng hindi gawin ng neuro exam.
Exactly, kasi usually yun yung namimiss. No? Patient already on triple antihypertensive drugs, losartan and hydrochlorothiazide, amlodipine, yet blood pressure is uncontrolled. Can we give clonidine?
Ang next po dun sa
Yan
guidelines.
siguro yung resistant, no?
Pag ang next po sa guidelines natin, pag on triple antihypertensives, maximum dose, one of which is a diuretic that patient might have resistant hypertension. So the next in the armamentarium is usually spironolactone, and then after nun, beta blocker, after nun, alpha blocker. So for patients with resistant hypertension, this is the time that you need to refer to rule out secondary causes of hypertension, kasi baka hindi lang siya your run-of-the-mill hypertensive, baka meron pong cause ng hypertension.
Pag nakakatatlo ka na, it's time to call the hypertension specialist, no? Thank you. Patients who have history of hypertension during pregnancy, so I suppose those who had preeclampsia or eclampsia, do they need lifetime medications?
Sometimes the nandito may maubi tayong kaklase. Usually 6 weeks you'll know if you need to start them on antihypertensive medications or not. But there are studies that show that if you have a history of preeclampsia and eclampsia, then your risk of developing hypertension in the future is high. So for patients who have preeclampsia, eclampsia, we follow them after 6 weeks and then try to see, yun yung peripartum period, di ba? We try to see if, kasi pag tinanggal mo naman yung baby, babagsak yung BP. We try to see if that patient has superimposed chronic hypertension. So after 6 weeks, malalaman mo, pag biglang bagsak yung BP, malamang preeclampsia, eclampsia lang yan. Pero pag halimbawa, mataas pa rin yung BP, malamang baka meron na siya.
Totoong hypertensive na. Especially, I guess, those who are getting pregnant later in life, no?
Madami ngayon.
Sumasabay na yung onset of the hypertension to the preeclampsia. Why are beta blockers contraindicated in the treatment of a hypertensive crisis belonging to a specific subset of patients like that of drug dependence and those with methamphetamine-induced hypertension?
Catecholamine excess kasi yon eh. So, alpha blockade muna. Actually, diazepines muna. Pag halimbawa, cocaine, lahat yan eh. You look at the the cause, the mechanism of action of these illegal drugs. So cocaine, usually it's because of catecholamine excess, methamphetamine, and your ecstasy, your mga designer drugs. It's all catecholamine excess eh. So it's your sympathetic nervous system. So basically what they do first is try to do benzodiazepines first. Ay, tanggalin muna, withdrawal, tatanggalin yung, 'di ba? Muna. Tapos if the blood pressure cannot be controlled, then usually alpha blockade, especially for cocaine, alpha blockade muna. Pag hindi, may ano po sa alpha blockade, alpha, ano ka eh, alpha. So pag nag-beta blocker ka, baka mag-crisis yun kaagad. So for cocaine, alpha blockade muna bago mag-beta blocker. For all others, usually benzodiazepines muna, usually bababa yung blood pressure nun. Pag hindi
Same
bumaba,
for
then you can...
methamphetamine? Baka
methamphetamine.
walang masyadong cocaine, baka mas maraming methamphetamine.
Methamphetamine, saka ecstasy. Serotonin excess kasi yon, haze, di ba? So you're dealing
So you would
with
use
your
an alpha blocker
sympathetic
first.
nervous system.
All right, good. We need to review our pharmacology for that. Okay. How soon should you reintroduce clopidogrel and aspirin that you stopped during a hypertensive emergency?
Hindi
Did you
naman
say
tayo
you stopped
nag-stop,
them?
di ba?
No, you don't.
Ikaw?
You don't stop. No, you don't stop aspirin and clopidogrel just because of a hypertensive emergency. Somebody asked about high dose statin in somebody with hypertensive emergency. I didn't hear you mention that.
Statin, basically, you give statin. There are 4 statin treatment groups, diba? For secondary prevention, if that patient suffered a stroke, a heart attack, then your patient should be given statins. But if it's primary prevention, again, yung guidelines, they say that you have to be 45 years and above with 3 risk factors, and the LDL should be more than or equal to 130 milligrams per deciliter. If your patient is diabetic, then automatic, you have to give that patient statin. If that patient has ASCVD, meaning stroke, heart attack, peripheral artery disease, then your patient should be on a statin. So depending on the type of patients that you have, whether it's primary prevention or secondary prevention, then that will guide you on when to give a statin.
But the statin is for the preventive part. It is not part of the treatment for hypertensive emergency. No, so
thank you,
that
Hazel,
should answer that. Now there are a lot of questions, Devi, but we were already told by our bosses to wrap up. Thank you very much for giving us your holiday today and sharing so much. I'm sure maybe we can take time to answer the questions offline later for those who have typed in their questions. So once again, thank you very much, Dr. Ona. We are grateful for your time and expertise and present you with this certificate of appreciation. Class 1998 would also like to thank those who helped make this webinar possible: the University of the Philippines, Manila, the UP Medical Alumni Society, the Postgraduate Institute of Medicine, the UP Information Management Service, and our sponsor for today, MedInfinity. We invite all our viewers to join the next webinar about blood cancers and health financing. Our expert speaker will be Dr. Anne-Christine Quero, an affiliate physician and junior faculty at the Division of Hematology, UPPGH, and a consultant in hematology at the Department of Internal Medicine in San Juan de Dios Hospital. This webinar will be held on November 3, this Friday, also at 12 noon. You can use the same Zoom link to register in advance or use the QR code that's being shown on screen now. To receive your attendance certificate for today, kindly answer the evaluation form, which you can now access through this QR code being flashed. We will also post the URL in the chat box now. You will be able to receive your attendance certificate only after answering the evaluation form. So please ensure that that the name that you enter in the form is actually the name you want to appear in your certificate. So it's been a good day. We learned a lot. Even the speakers learned a lot. See you next time as we continue to unlock knowledge for primary care workers and allied medical professionals. God bless you all and stay safe. Thank you.